Birth planning. There are several different options when it comes to birth planning. Many of us are familiar with hospitals, of course. We do have some birthing centers, and then, of course, our home deliveries. And we'll talk about each of those. Now, with a hospital setting, of course, we have the advantage of having available trained personnel like your NICU nurses, just in case something goes awry, or if you were to have a preterm delivery, something of that nature. You have respiratory therapists readily available. Of course, if you need labs to see if there's something specific going on with an infant, then you also have lab technicians who are readily available for, to run those labs. So two of the greatest advantages to delivering in a hospital is one, the availability of trained personnel just in case there are any complications during delivery. The second is if there are complications or a preterm delivery and both you and your infant are in the hospital, then if you're in a hospital setting with a NICU, then you are not going to be separated from your infant. At least you can um, wheel yourself upstairs to visit your child while you're still in the hospital waiting on discharge. Now, we also have birthing centers, which birthing centers are a plus. It may not change as far as cost, but birthing centers are focused solely on childbirth. It's family focused. We want to include everyone in birthing centers, whether it be siblings, parents, grandparents even, are one of the advantages to birthing centers. There's not a whole lot of limitations as far as who can attend. Now, birthing centers, you do have to take into account that they do not want any high-risk pregnancies here. They will not deliver your infant in the birthing center if you are at high risk. So birthing centers, number one, are considered ideal only for those women with low risk pregnancies. Any complications of pregnancy or a cesarean would negate that woman's ability to use a birthing center. They just simply do not have those capabilities available, nor do they have the staff in the event of an emergency of that nature. Of course, the birthing centers, they try to make it so that it's similar to a home environment, even though we all know that being in a hospital or even a birthing center, clinic, something of that nature is never like being at home, even though we do have a few more amenities to take care of your infant in a birthing center and a hospital. So the takeaway for birthing centers is specifically that it's family focused and they absolutely do not take any high risk pregnancies. And that would include any woman who has some type of heart condition or just a high risk pregnancy altogether. So those are two very important things. Now, lastly, let's talk about home births. This is just typically a birth that's taking place in the comforts of your very own home. And they're typically attended by either a midwife or a doula, whichever they prefer. Now, as far as mortality rates, of course, they've been doing these for quite some time now, and they have tend to statistically drop in the number of deaths during home deliveries. Of course, at home, you're surrounded by family. The only disadvantage to that is, yes, you do have a midwife available, but you do not have access to that high quality medical experience. Home births have been performed for years and years all over the world. One advantage to a home birth is cost. It tends to be a lot less expensive to birth your child at home rather than in a hospital. It's typically stated that healthy pregnant women typically do not have any complications during a home birth. Sometimes I tend to disagree with that, and I suppose just because I have worked in the NICU setting and I've seen infants come in by ambulance who were delivered at home, and the consequences of that home delivery was not good. The infant's cord was wrapped around the neck, and so you can imagine being without oxygen, what that has done to that infant during that time period, even during the transition from home to the NICU. So I tend to disagree with them being completely safe. No delivery goes without some risks. So another thing is birth plans. Many mothers will come into a facility with their birth plan in hand. Now, a birth plan is just their thoughts and how they want or how they think their delivery should go. Those typically include, like, they do not want any medications given to them for pain. They do not want any artificial rupturing of that membrane. They want it to just naturally occur. They even talk about how they want the lighting in the room, or music or no music, or I do not want an episiotomy. I just want it to naturally take its course. They may even state in there to the physician, I do not want forceps used on my child. They may talk about who gets to cut the cord. Now, also, when they're talking about cutting the cord, they also typically have in there some moms will even say to you, I absolutely positively do not want to go to a C-section unless death of my infant is imminent. Now, 9 times out of 10, when your parents come in with a birth plan, I promise you 9 or at least 8 out of 10 of them end up with a C-section. It's almost like voodoo. So, or that black cloud. When you bring that in, you're automatically going to get a C-section. It seems to be that way. They may also talk about their infant and that they do not want them to have that vitamin K injection that we typically give, and they can decline that. That's their beliefs, and they do not have to consent to that. They also, in this birth plan, may talk about cord blood and whether they want that stored or saved and things of that nature. So that is your birth plan and the settings. Now, there is a link on this slide to a home birth. If you want to watch that, feel free. Some of you may not want to, but it is there for your viewing. So normal labor, there are 2 theories about the cause of the onset of labor. It's not quite definitive, but researchers have 2 theories in which we will talk about, and that's the mechanical changes that happen in the body and then their hormonal changes. The first one is mechanical changes, and this one is just based solely on uterine stretching. So basically what it's referring to is, if you can think about this, a hollow body organ, and it reaches a certain state of distension, and it spontaneously contracts and empties. So it's kind of like your bladder. So once your bladder's full, it's going to empty. If your stomach is over full, then it may cause you to vomit. So basically just think of it that way. You have a hollow body organ, like your bladder or your stomach, and it reaches a certain state of distension, and it can no longer hold anything else. Nothing else can come in. It can't contain it any longer, and it just spontaneously causes a contraction and empties the contents. So that's what they're talking about when they're referring to the mechanical changes. It's just that uterine stretching. It's reached its absolute maximum ability to hold anything else, and then it starts that contraction to expel that fetus. Now, hormonal changes has been theorized as either an increase or a decrease in hormones. So with oxytocin stimulation, one of them is one that is talked about. Now, oxytocin, of course, is released into the bloodstream and causes the cervix and uterus to stretch. And that's where they think possibly that hormonal change could occur to bring on labor. So you talked about progesterone several times and about the fact that it is one of the hormones that's needed to maintain a healthy pregnancy. So one of the theories is that there's a drop in the progesterone near the end of the last trimester, which brings about labor. Um, it's not been proven specifically as to how that happens, but just know that some of those hormonal changes can include a progesterone withdrawal. Studies are still unclear as to how it actually works, but they think it relates to the placenta and the changes in the placenta in preparation for birth. So it stops the secretion of progesterone. So estrogen and progesterone kind of work the same way in this theory. They're unsure of whether its onset is because of a decrease or an increase in the two hormones. So just be familiar with the fact that those two contribute to the hormonal changes. Okay, and then lastly, we have fetal cortisol, which we all know that cortisol is our stress hormone. In relation to cortisol, they feel as though fetal cortisol plays an important part in the onset of labor because of the differences in labs that were drawn from infants who had been born by C-section versus those who were vaginal deliveries. It was seemingly much higher in those who were born vaginally, which led them to believe that a higher cortisol level is what starts the onset of labor. Signs of impending labor. So the first one we're going to talk about is lightning. You may have heard older people talking about, oh, your baby's dropped, you're soon going to be in labor. Typically, it's noticeable in nulliparas, and remember that just simply means a woman who has never delivered a baby. So 2 weeks prior to labor, they'll notice a drop in the fetus, and it's basically dropping into that pelvic area, getting ready for delivery, settling into that birth canal. Now, with this happening, parents typically, or moms typically, have that return of urinary frequency. Okay, it's dropped and it's back, affecting that bladder. Now, it does also give them some um, relief in respiratory. So they're able to breathe a little bit better, a little easier, because they don't feel as though those feet are pushing up on their lungs. So that is alleviated just a little bit with that drop. So remember, lightning actually means a drop in the fetus in the 2 weeks prior to labor. Now moving to seepage. Seepage is just an outflow of fluid from the vaginal area. Now we do have to differentiate between urine and amniotic fluid. There have been patients who come into a facility to say, I'm not sure if my water broke or if I just peed myself. And so we always want to be careful with that because the risks of infection it can pose to our fetus. Now, I know you think that's funny, but sometimes when that baby drops and you have parents or moms, their urinary frequency comes back and it just happens. And so they're first time moms and they're not sure, did I pee myself or has my membrane ruptured? So they have a legitimate concern. So the way we test for that is a test called a nitrazine test, which we will use a little piece of paper and test the pH of those fluids. Um, so make sure you know the difference between a non-reactive and a reactive test. Now, this is actually on your page in your book on page 799 in box 27.1. So we'll talk about the nitrazine testing. So let's talk about the non-reactive first. So a non-reactive test simply means that your membranes are still intact and it was probably actually urine. They've just wet themselves. So that's going to be an acidic pH. So you're going to see that yellow on the testing strip and it's going to be a pH of 5.0 all the way up to 6.0. Okay, so you can have a yellow test, or testing strip. Um, it can be even olive green. So again, this is going to be your acidic test. You're actually pulling fluids from the inside of that vaginal area with a sterile Q-tip applicator, whichever you have available, to pick up some of that fluid for testing. Now, when we move on to reactive testing, that means your membranes have ruptured and there's a presence of amniotic fluid. Now, amniotic fluid is more alkaline, so your paper is going to turn blue-green, gray, or a deep, deep blue. So you'll see that they're all blue if you do have, in fact, a rupture of membranes. So since it's alkaline, you're going to have that pH of 6.5 up to 7.5. So remember, alkaline results signify ruptured membranes, which means delivery is probably imminent at that point. Now, there are some instances of false testing or false positives, and that's just related to some different things, such as either a little bit of bloody show, or maybe there's just not enough amniotic fluid for testing. And sometimes even semen can skew the results of the nitrazine testing. So make sure you know the difference between the two and what your colors would show and the pH for testing purposes. So if we have a reactive test, meaning our membranes have ruptured and labor does not occur within the next few hours, they're typically going to give this mom something, they're going to admit her and start oxytocin. So at this point, when we're starting to initiate labor, we're going to decide on whether this is a preterm delivery or if it's an infant who's closer to term, just so we can calculate like the lung maturity and if we feel like we need to give mom those glucocorticoids to help those lungs along before delivery. And remember, those are given to mom, not the infant at this time. Now, we talked a little bit about the bloody show. Now, this just means a blood-tinged mucus that is present. And sometimes people talk about a bloody show when they've lost that mucus plug. Now, the mucus plug is just a portion inside that covers that cervical OS, or just the opening of the cervix during pregnancy. And typically, once you lose that mucus plug, there is a little bit of bloody show that they refer to. And typically, right after the loss of that mucus plug, you'll start to see these moms deliver very shortly. Now, with contractions, there's a video link here. You can look at that after this slide. But there's Braxton Hicks contractions, and you need to know the difference between true in labor contractions versus Braxton Hicks contractions. Okay, so Braxton Hicks will start typically somewhere during the first trimester. And those should not become regular. They're typically kind of irregular, and they should never, ever, ever lead to dilating of the cervix. So that's one of the things that differentiate regular contractions during true labor and Braxton Hicks contractions. Braxton Hicks contractions will not dilate the cervix, okay? So going forward, remember that the difference in the two is that Braxton Hicks are typically irregular and do not dilate the cervix, whereas true labor contractions are going to become regular and you're going to see that dilation occur. Now, sometimes right before delivery or the onset of labor, you'll see moms, they'll have a slight weight loss, not a lot, just a couple of pounds. Now, lastly is effacement. Now, true labor is signified by the onset of regular rhythmic contractions that causes that cervical dilation and then ultimately effacement. Now, effacement is just the thinning and the shortening, or basically the obliteration of the cervix that occurs during late pregnancy and birth. So there is a video on here that's linked in this slide. If you guys will watch that, they explained effacement really well. So I would encourage you to watch that. It's a visual that will help you during testing time. You'll refer back to that and understand more about effacement and what that means. Now, in this slide, we're going to talk about the difference between false labor and true labor. And you need to know the difference in the two. This test will not be open book, so make sure that you understand the difference between false labor and true labor. So false labor, I will tell you to begin with, is just an irregular, maybe contractions. They rarely ever have a pattern. Okay, they vary in length and intensity. And they're most noticeable in the fundus. Remember we talked about the fundus is the top of the uterus. Okay, so they'll start to feel that in the very top of the abdomen. Now, with false labor, you'll see that I have on here that it stops with relaxation interventions. So with that decrease in activity, or even if they empty their bladder sometimes, it will stop that. And you'll notice that that will go away. So you'll know that that is a sign of false labor. False labor, again, important part here, stops with relaxation interventions. Okay, so if I'm up walking around and I think I'm in labor and I think to myself, I'm just going to have a seat in a chair and relax for a little bit, and those contractions go away, then that is false labor. Okay, and again, false labor, you're not going to see that effacement. And remember, Braxton Hicks contractions will not dilate that cervix. Okay, and then also in false labor, you're not going to feel or see any change in that fetal position. They're going to remain the same. You haven't seen that drop just yet. So remember your takeaway with false contractions. The biggest, most important part is they're going to notice it in the top of that fundus, in the fundal area, and it stops with relaxation and no dilation. Now, in comparison to true labor, you're going to see those contractions become regular. They're going to get closer and closer together. They're going to be stronger, and they're going to last a whole lot longer. Now, one way to kind of differentiate the two also is sometimes Braxton Hicks contractions are felt more so in the lower back area rather than in the fundal area. So when you're experiencing those contractions, they're going to start to feel those true labor contractions at the top of the uterus, that fundus. It's gearing up to deliver the force needed to expel that fetus. So here's one difference in false labor and true labor. With true labor, if I'm up walking about, they're going to continue to get stronger, those contractions are. And if I decide to sit in my chair, they are not going to stop. Okay, so they do not go away with true labor. Whereas with false labor, I can sit in a chair, relax, and they will typically go away. Now, we talked about the Braxton Hicks and how sometimes they'll feel those in the lower back. In true labor, they will start in the low back and then they will travel to that lower abdomen. So that's where you're going to start feeling those, is in that lower abdomen, in that fundus area. And again, it does not stop with relaxation. No matter what you do, that baby is coming. Your contractions are going to continue closer and closer and stronger and stronger. Okay, so they remember that. That is extremely important to remember and to be able to tell the difference between true and false labor. It does not stop. Now, the other thing that you can use to differentiate true labor versus false labor is that fetal position. You will continue to see that fetus descend into that pelvic area. So your baby has dropped, it's ready to be expelled by those contractions. Okay, so be sure you know the difference between false labor and true labor and the signs for each category. So in labor and delivery, we typically just follow the standard precautions unless we know that there's a risk of certain things as far as MRSA and things of that nature. So of course, we're going to always wash our hands. We're always going to wear gloves. When we're actually assisting with the birth, whether you're in the delivery room or in a patient's room, you're always going to wear that gown, mask, and a shield. Okay. Now, typically, your techs will drape them with sterile towels. You may have to help, but you want to make sure that you're avoiding their sterile field, that we don't contaminate, because if we contaminate that field, there's a ton of stuff in there and they can't reuse any of that. It has to be reprocessed. So that's very time consuming, especially if it's an emergent situation, and costly. So we want to try and avoid those things. We always want to make sure that we're providing as much coverage as possible, just to maintain their um, privacy. Always wear your gloves and gown when you're handling a newborn. Um, it, I have seen many, many times newborns come out and they're sweet, they're cute, and they're always covered in that vernix and everything, but we may not always think about infants being carriers or infected with something. But if you have a mom who just comes in, don't know the history, she drops that baby out in the ER and she's HIV positive or herpes positive or anything like that, you do not want to be touching that newborn without the proper PPE. You just don't want to put yourself at risk. Of course, when you're suctioning that infant, always make sure that you're using the appropriate method. Remember, if you can't remember how to suction, remember your ABCs. You want to suction that mouth first and then the nose. And always be sure that you're using a bulb suction if available, or that your suction settings are appropriately set prior to beginning that suction process. Now we're going to move on to the processes of labor and delivery. We're going to talk about the passageway, how we get the infant from there to the real world, the passenger, who is the fetus, the powers that move that fetus through, which is contractions, and then the position of the mother, which is standing, walking, side lying, hands and knees, just as positions for delivery, and then their psychological responses to delivery or during delivery. So let's start with the passageway first. So the passageway is simply the pelvis, and we all know that. The pelvic area, the superior portion here of that pelvic area, um, the iliac segment, that is what supports the uterus and the fetus in the last few months of pregnancy. Okay, this is what directs the fetus into the inferior portion of the pelvis, or otherwise known as the true pelvis, which is this area here that you can see. Now, the most important part about the true pelvis is that that infant's head must be able to pass through that true pelvis in order for a vaginal delivery to occur. Now, the true pelvis is divided into three segments. So you're going to see first the inlet, which is here. This is separating the false pelvis from the true pelvis. Okay, so that's important. The inlet, and then you have, of course, the cavity or mid pelvis, which is this portion here. And then, of course, your outlet. This is where the baby's head comes out and we've entered into the world. We talked a little bit about the evaluation of the size of the true pelvis and the importance of that. Again, the importance is, yes, my baby's head may actually fit in the inlet and the false pelvis easily. But when it comes to delivery, if that head is huge, and I've seen some very large babies delivered, if that true pelvis cannot contract far enough, or dilate far enough to deliver that head, it's not coming out. So the importance of that is that baby's head has to be able to get through that true pelvis. Okay. And the way they evaluate that is, number one, they can palpate that through a vaginal exam. They can use the pelvimetry, which is basically just measuring that true pelvic size. Typically, they'll do that through ultrasound, measuring this here. Okay, so you can look on page 26.2 on page, I'm sorry, table 26.2 on page 801. Nope, sorry. That should be page 801, and that's going to be figure 27.1 to show you the actual pelvic area, and it'll show you the different areas. There's another slide following this one that shows this in a little bit larger view. So we've talked about the false pelvis, the true pelvis, the inlet, and the measurements. So palpation can help determine the distance between the two, but they can't visualize it. Like with pelvimetry, they will use an x-ray, which they can actually obtain pretty accurate measurements of the bony prominences. Um, it's done during pregnancy, but do we want to really risk exposure to those x-rays to that fetus? So what they can typically use, as I said, is an ultrasound because it's safer and it's just as adequate in measuring that area here in that true pelvis. So we're not exposing mom or baby to any radiation. So we're doing no harm to mom or um, that fetus. So be mindful of that. We always want to use the safest and least invasive when we're testing. So then if you guys will look on page 800 on table 27.2, we'll talk about some of the actual pelvic types. Now, the most common is, of course, you'll see the gynecoid or just the round. That's the most common. Those are the ones that we really like because those tend to deliver easier without intervention as far as C-sections and things like that. Now, if you have a heart-shaped pelvic area, most of the time that's where you're going to see your C-sections come into play because if you can imagine your inlet area and that true pelvis, it widens at the top just like the shape of a heart, and then it tends to slender down as you hit the exit part. So just a couple of those. The oval and the flat, of course, are the wider ones, but those are typically less prevalent in pregnant women. So just remember that. Your round is the most common, and your heart-shaped is typically the ones you see delivered by C-section because that true pelvis is too small or too narrow for that infant head to completely exit through. So starting with the passageway, let's talk about the soft tissues, beginning with the uterine tissue. So the uterine tissue is the wall of the upper section of the uterus, or the top of the uterus, okay? So it has that thick muscular area, and that's what provides the force during those contractions. So that's why when I said you talk about the contractions in the beginning of labor, the onset, they start at the very back and move their way to the front of the abdomen. That's in the upper section. That's where it's going to start feeling those contractions to give that force to push that infant through the other areas that it needs to go through in order to be delivered. Okay, so the walls of the lower section just become thinner as that contraction forces that infant through. You're going to start to see those become smaller and smaller, and they just basically act as a passive tube. So once that starts to thin out, just think of it as, something being forced through a straw. Okay. Now, the cervical tissues is where we talk about effacement. Okay. So as the contractions at the top, that muscular portion applies that pressure downward, and we're starting to efface those contents right in that cervical tissue. We're shortening that cervix basically. And if you guys will watch the video at the end of this slide, it can really help you visualize what we're talking about when we're talking about effacement and shortening that cervix, okay? Um, so the vaginal area is extremely flexible. We don't really think a whole lot about that, but it is probably one of the most flexible parts of our body and our tissue. Um, so the vaginal area also, of course, has an increased blood supply during that time, a lot of thickened mucosal linings, and some. So when we start seeing that contraction push that fetus through, you're going to start seeing that loosening there in the vagina of those connective tissues. Okay. Um, so that's really where you start to see that stretching come into play. Now, the perineum, or that perineal area, once that baby's head gets down to the end of the vaginal canal, that's where we're at greatest risk for tearing. If that baby has a really large head, and maybe, or even the shoulders sometimes in that pelvic floor, they're thin, they're stretched, and maybe that presenting part just is not quite going to make it through. So sometimes they're at risk for tearing, or you may see them actually just go in and make a slight cut in order to get that baby on out. So watch the video that's at the end of this slide. It will truly help you understand and relate to those, that uterine tissue, the contractions, and how that works to efface that cervical area, the shortening of that until delivery. She's quite entertaining too. So let's talk about passengers. Sometimes you may have one passenger, sometimes you may have two. It just depends on the number of fetuses involved in the pregnancy. So let's talk about how we get those passengers safely into the world. So the fetal head is the largest part of the body to be delivered, and that's really the largest concern. Sometimes we do become concerned about shoulders, and I don't know if you've heard about shoulder dystocia. Sometimes that can occur during delivery if they have broad shoulders. Um, and so sometimes we talk about getting stuck when we talk about shoulder dystocia, or we're going to say the head's delivered, but their shoulders are stuck. And the last thing you want to hear when you're delivering a baby is that something is stuck. If you watched the last video, you heard her say it true too, and it is a true statement. Nothing worse than hearing the word stuck when you're trying to deliver an infant. So if you guys will look on page 802, you'll better be able to follow along and understand what we're talking about when we're talking about the skull areas. So for the infant, their skull is not fused. That that is what allows for that little bit of movement and some overlapping when we're delivering, and that's how we can really deliver that head safely for the most part through such a small diameter. So when babies are delivered, we all probably joke about cone heads, because many times when an infant has been stuck in that birth canal for any given length of time, they do tend to look like a cone head. However, that is not really what we refer to or document as nurses. So it's usually referred to as molding. So when they come out and they have that head that's misshapen and it truly looks like a cone, it's referred to as molding. So for all testing purposes, it's going to be molding. So there's several major bones in the skull. There's two frontal bones, two parietal bones, the temporal bones, and then of course the occipital. So when you look at the picture on 802, you'll see the tiny lines that divide all of those. Those are called suture lines. And because they're not fused, that's what allows that pliability and delivery. So if they were fused, like ours become fused as we grow, we would most likely be facing a C-section because there's no way to get that head through the vaginal area if there's no pliability or the ability to overlap those bones, because then it's just 9 times out of 10 too large to fit through that true pelvis. So actually, when we're talking about their parietal bones and things like that, we talk about their fontanelles also. Sometimes you can actually see a heartbeat in that area. If you have a fetus who may be slightly dehydrated in that fontanelle area, you can actually see and feel a pulse. So when we're trying to decide what position that fetus is in, whether it's breech or feet first or head first, physicians can actually do a pelvic exam and palpate those suture lines to see what the presenting part is. And we'll talk about different presentations here in the next couple of slides. So just a couple of things to be extremely mindful of, take notes about on this particular slide is, and to be mindful of is when we're talking about the fetus and the skull moving through the vaginal canal, one of the main parts is, of course, molding and what that looks like. And then the other is the largest part that goes through the vaginal outlet or the pelvic outlet, and what is that called? So the two parietal bones are the largest part to go through the pelvic outlet. So if you were to see that on a test or ATI, you will know that the largest part or the largest diameter to fit through that pelvic outlet is going to be those biparietal bones. Remember, you have two of them. You have one on the right and one on the left. So the biparietal bones is the largest diameter to fit through or to go through that true pelvis. We're still talking about passengers and the fetus. So we're going to talk about several different things here. We're going to talk about fetal attitude, fetal lie, fetal presentation, and fetal position. So if you want to go ahead and watch this video prior to, then you might understand just a little bit better about the Leopold's maneuver, or you can wait until after we talk about it, and that may help you visualize a little bit better. So let's start talking about fetal attitude. So that's just a relationship of the fetus body parts to one another, meaning we're talking about flexion, extension, things like that. So what we want is flexion at delivery. So we have that back sort of in a bowed position, the arms are crossed and the legs are crossed. So we've used the term many times about curled up in the corner in a fetal position. So this is what we're referring to, flexion. It's the best position to allow for the easiest approach when entering that pelvic area for delivery. Okay, so flexion, arms crossed, legs crossed, and that back is in a curved, almost like a bow. Now I'm going to say these can be a little confusing, so if you need to watch the video and then come back and revisit this slide, please do so. Eventually it will all come together once you put one or two of them together. So let's look at fetal lie. You'll see there's longitudinal lie and there's also longitudinal lie in breech position. So you have vertex and breech. And it doesn't really matter if they're breech or longitudinal. What's important is that the spine of the fetus is aligned with the spine of the mother. So if you look at the transverse position on that slide, you'll see that the transverse position, the spine actually cross. So the mom is going longitudinal and the other one is going in a transverse. So the easiest way to remember that is, of course, if it's a longitudinal lie, the two spines make a small L. If they're transverse, meaning they intersect or cross, then it makes a small t. So that's how you can differentiate the longitudinal lie versus the transverse lie. Now let's move on to fetal presentation. That just simply refers to the part of the fetus that's going to enter that pelvic area first. So we know whether that's their head, their buttocks, or shoulders. So that's what we're talking about with fetal presentation. Okay, it's important that the physician know that if this baby is breech or not, because if they come in breech, they're most likely going to get a C-section. Now, there are some physicians who will attempt to manipulate that if they're not too far down into that cervical area or the pelvic inlet there. They will actually try to manipulate and turn that baby around to avoid having to do a C-section. It's rare, but there are a few physicians that will try and change those positions to avoid C-section for those moms. One reason that's important is if we're trying to deliver an infant, say they come in and they just came in through the ER and we're delivering this baby vaginally and that physician doesn't know the presentation, whether it's head or buttocks first, and you start delivering and the feet come out, the buttocks come out, the shoulders come out, and then you're stuck with this big head because that inlet is too small. We all know that when it comes to delivering infants, stuck is definitely not a word we like to hear. So typically if they're a breech infant, meaning feet first or buttocks first, they're going to end up with a C-section. So you can see how that would be important for that physician to know. If he was in an emergent situation, he can figure out what the presenting part is without ultrasound. Now we're going to talk about fetal position and the Leopold's maneuver. So I did attach a video for the Leopold's maneuver, so hopefully you'll watch that and have a really good visual as to what we're talking about when we're assessing that fetal position. So if you look on page 803, it will actually show you about the Leopold's maneuver. It's at the top of the page on figure 27.3. So when they're palpating here, they're just palpating, like you can see in the video, what the presenting part is. And some may tell you that it's maybe difficult to differentiate between the head and the buttocks, but really, if you're thinking about it, even though their sutures are not fused, they still have a little bit of a harder feel rather than that soft tissue on the buttocks. So you can tell the difference, and most physicians who have done this for a very long time are able to immediately have that distinction between the buttocks and the head. So when you look at page 803 and we're looking at figure 27.4, this is what they're looking for when they're doing that Leopold's maneuver. So if you look at the bottom right corner, you'll see that LOA is what they're talking about here. And this is how they will chart the fetal position. So the LOA simply means that the head is pointing to the left, and it is in the anterior or frontal portion of the pelvic area. So basically the back part of their head is facing the anterior portion, the front portion of that pelvic area. So that's where they get the LOA. So then if you look at the ROA, which is then on the opposite side, this is the next most common position for delivery. And so the ROA simply just means that the head is pointing to the right side of that pelvic area in the anterior portion. Now, to show you the difference, if you look at the top, you'll see the ROP and the LOP. So this kind of gives you a different look. So the ROP is the occipital part is pointing to the right portion posterior of that pelvis. Same thing with the LOP. So the LOP is just basically that head is pointing toward the left part of the pelvis posteriorly. So the difference between the ROP and the LOP is just basically which side, left or right, that head is pointing to. Same thing with the right and the left when you're looking at ROA and LOA. The only difference in those two is that they're facing left or right. So just be careful with the posterior and the anterior. Okay, so when you have LOA or ROA, that head is pointing toward the anterior portion or the front of that pelvic area. And then the ROP and the LOP are facing the posterior part of that pelvic area. So be sure that you know what the most common one is and then the second most common. Okay, and remember we talked about the LOA is the most common and the ROA is the second most common presentation or position. This might help you in remembering ROA versus LOA. So the first letter is always the maternal pelvic side, left or right. The second is always going to be your fetal presenting parts. Hopefully it's the head. And then the third part is just simply anterior or posterior. Just a couple things to be mindful of. When we talk about the Leopold's maneuver, you always want to make sure that you have allowed your patient to empty their bladder first. There's nothing worse than having someone in there manipulating this fetus and having to go to the restroom. So make sure that you have offered them restroom privileges to empty that bladder. A couple of ways to identify when they're doing this Leopold's maneuver, the presenting parts. A couple of things to remember is, of course, the head is firm, like I talked about, and it kind of will move just a little independently of the body. You'll be able to feel it move side to side, but you'll also be able to feel that firmness. Now, when you're trying to decide whether you're on the spine or if you're on the frontal part where arms and legs are crossed, you'll just want to remember that the back side is going to feel smooth, okay, when you're moving that hand across that area. And if you are in fact on the spine, then of course the other side is going to feel like some just little nodules. You'll feel those knees and elbows of that fetus. That's just a couple ways to help you determine those presenting parts. When we start talking about monitoring the fetal status during delivery, we always want to make sure we're monitoring heart rate. That can lead us to so many things that could be going on with that infant, especially if they're stressed. That's one of your first indicators. So when we're monitoring, we do have some continuous electronic monitors. If you're looking on the screen, you can see there's two sensors here. Those are our So when we talk about decels and late decelerations, sometimes you'll see a dip in the heart rate and it will return to baseline, but it's extremely slow in its return. So late decels are always bad because it signifies that placental insufficiency. So something is preventing that flow to the infant. Okay, remember our placenta is what gets the oxygen and blood flowing to and from our fetus, so we do not want that compromised. Now, if we do have that compromising situation in those late decels, it can cause hypoxia, which of course we all know with hypoxia, that infant is not getting any oxygen to the brain, and therefore we're going to see some effects, CNS effects from that hypoxia. Now, sometimes we may run into a prolapse cord, and what that means is you may have a mom come in and you're going to put that monitoring system on and you're going to see that fetal heart rate just bomb to the bottom, and it's extremely slow to come up. So if your physician goes in to check that mom, he's going to see that prolapse cord, and what that means is that's the presenting part that is in that delivery area first. So you can imagine, if you guys can look on page 27, you can kind of see that physician's reaching in with that prolapse cord in the upper corner in the left. You can see he's trying to push that infant's head away from that vaginal canal or that inlet so that it takes that pressure off the cord so it's no longer compromising that infant status. Now, they may hold that for just a moment, but you typically are rushing this mom to the OR because the minute that physician brings his hand or fingers back out, they're going to compromise that cord yet again. So a couple things we can do to prevent that hypoxia and those side effects of that prolapse cord. We'll talk about those. So first of all, you want to make sure that your physician is always using sterile gloves because he's up in that area. And of course, that is a huge route for infection if that placental sac has in fact um, broken. So in order to prevent that compression on that cord, we can put mom in what's called a modified SINS, or you can put her in Trendelenburg. So if you put her in Trendelenburg, of course her head's going to be down, and that's going to alleviate that pressure off the cord until we can get her into an OR. Sometimes you can put them into a knee chest position, and you'll also see that on page 805. So if you put them into those two positions, you can see that cord is no longer compromised, and the hypoxia and the decrease in blood flow is no longer there. So we'll want to keep them in those positions until we can get them into an OR for a C-section. So remember those two ways to prevent that: the modified SINS, Trendelenburg, or the knee to chest. Okay, just whatever position works the best to keep that pressure off of that cord. Now, one other thing that it mentioned here is meconium. I may have mentioned this previously. Meconium can be a huge, huge factor in delivery. This is when that infant has become stressed. So if that cord is compromised and he's not getting the oxygen and blood flow that he needs, he is stressed. So what happens is when they're stressed, they release that first stool, and it's a really thick tar-like stool. So what happens is they're in there, and of course they're swallowing this and they're inhaling this, or this is entering into their lungs. So you can imagine having that thick tarry stool in your lungs. Some infants really struggle with this, and we've had some die from meconium aspiration. So as it's aspirated, this meconium, they can deliver, and they immediately go into acute respiratory distress. So what's happening is it blocks that blood flow or the airflow in our little alveoli, or those little air sacs. They can't expand, so then we're still not getting the oxygen that we need. It's just trapped in there. And sometimes this meconium, they have found this in even years and years later, the residue in there. It's a huge irritant to the lung tissue. Um, it basically inactivates the surfactant that is present. Okay, remember we have to have that surfactant in order for our alveoli to function appropriately also. Now, depending on the amount of meconium that that baby has inhaled will depend on the severity of that. A lot of time post-term babies, when they're overdue, past 40 weeks, they're typically some of the others, some of the most that get stressed and are end up in a NICU with that on ventilators, pulmonary hypertension, and these are the infants you're going to see put on nitric. So this is why we continually monitor that fetal heart rate. It can tell us a lot about what's going on in there. Now, the placenta is also considered a passenger. So after we deliver the fetus, of course, they still have contractions and they're still pretty strong, and that allows for the delivery of the placenta. Okay, so it reduces in size and it separates from the area where it was implanted. Now, the first couple of contractions after birth, it basically shears that placenta away from the base. So the delivery of the placenta completes our third stage of labor, usually about 15 to 30 minutes if it's naturally delivered, and then of course 5 minutes if you're doing a C-section and they manually remove that. We always want to make sure we're examining for the intactness to make sure that there is not any residue or residual portions of that left in the uterine cavity. Okay, we usually measure it, inspect it to make sure there's no odd looking parts of it. And then we also palpate the uterus until it's firm to expel any clots that might be there. So if you've ever had someone come into your room, especially those of you who have had children, you'll probably remember them coming into your room and they're talking to you about massaging your fundus. So it's really not a massage, it's kind of misleading. And we'll talk just a little bit more about that. But we always want to make sure that the complete expulsion of the placenta has happened. We don't want to leave any of it in there. And then monitor for firmness after that placenta is delivered. And we'll talk about measuring and assessing the firmness. When we talk about powers, we're going to talk about primary and secondary powers. So we're going to talk about the uterine contractions. Now, during labor, the muscles in the upper uterine segment or the fundus contract at certain intervals. And you'll see that early on, they're about 15 to 30 minutes apart and they last about 20 to 35 seconds. So then later on, as labor progresses, you're going to start feeling those 2 to 3 minutes apart, and they're going to start lasting longer, and they're going to start feeling more of extreme intensity with those contractions. Now, the primary is the signal of the beginning of labor. Okay, so that's going to be your early contractions. This is where effacement begins. Okay, the effacement is just the shortening and thinning of the cervix. Remember that balloon video that you watched? So what's happening is we're starting to dilate, we're effacing that cervix, and we're preparing for the descent of that fetus. So they do typically check for effacement, and they'll say, "Oh, I'm going to check mom." So they'll just check that to see how effaced they are, and you may hear them say, "Oh, effacement, mom's effaced 0%, or she's 50% effaced, or she's 100% effaced." And what that means is that cervical area is, you're able to feel a whole lot more. So you can feel more of that baby's head rather than just the cervix itself. Okay. Now, once that cervix has thinned and there's all of that added pressure there, this is when your mom's going to start feeling that intense, uncontrollable urge to just bear down. Um, as strange as it sounds, even some paraplegic women um, will be able to feel those normal uterine contractions. So they're always going to say, "Oh, I feel the need to push," but we want to make sure they're fully dilated before we start allowing them to push, because the important part of that is if you start pushing and you're not completely dilated, then your infant could possibly get stuck in that outlet. Remember, we want to make sure that we're completely dilated. That's important. So the secondary powers is the bearing down efforts. Okay, when she starts to feel that urge, she should only push when she feels that urge. Okay, once she's fully dilated. Because if we start pushing again and that head gets stuck, we're going to cause some injury or some hypoxia. Okay, so we don't want her pushing before she's fully dilated. So again, the primary powers are going to be your signals for the beginning of labor. That's going to be your early contractions, your effacement, and the descent. Okay, so then our secondary powers is that bearing down effort. Okay, just be mindful. We cannot push before we're fully dilated to 10 because of the risk of injury. So this is just giving you an example here of effacement and the thinning and the shortening of that cervix. So as they start to efface, you'll see that there's 0% in the first one. So it's pretty hard to feel the baby's head because it's not quite thinned out yet. So as we start to thin out, you'll see that baby dropping a little bit more. This is just like that balloon video or that example in that video where she used the balloon to show you that effacement and the shortening of that cervix. So then you'll see once we reach to 100%, you can see that you can reach in and feel that baby's head probably um, much, much better than in 0%. Okay, so that's where our effacement comes in. That's where you're going to start seeing that dilation. Usually at about 100%, you're going to start seeing them dilate right about in here. So the mechanisms of labor, you guys need to remember this. The mechanisms of labor are when the fetus moves throughout the pelvic area. There are several maneuvers that are necessary, and these are called the cardinal movements of labor. So each of these stages that this fetus goes through to make its way into the world through those maneuvers are called the cardinal movements of labor. So first let's talk about the engagement. So engagement is basically just when those biparietal bones or that part of the head crosses into the pelvic inlet. Okay, so remember the largest part of the head that crosses into that inlet is the biparietal area, that biparietal diameter of the head. Okay, so at that point, that is said to be fixed or engaged in that pelvic area. So then we start our descent. Okay, so it's just the downward progression of the presenting part. Hopefully, it's going to be the head. We like it when their presenting part is the head, okay? Now, the amount of progress is measured basically by comparing the lowest point of the head or presenting part with those ischial spines. So if you guys will look on page 809, you'll see in figure 2711 the measurements that I'm talking about. So they're referred to as stations, and they're measured in centimeters that are either above or below the level of the spine. Okay, so if you look, this baby's head is just below 0. So I would say he's at a station 1. Okay, so if it's 2 centimeters above the spine, we're going to see that -2. So if you look right at the bottom of the head, you can see that looks like a little portion of the spine. So remember, above or below, it's measured in stations, in negative and positive, according to whether or not it's above or below the spine. Okay, now with internal rotation, that's just simply talking about the shoulders being in line with that pelvic inlet. Okay, this enables your head to progress through that pelvic area. So moving on to stages of labor and delivery. So we're first going to talk about the stages. The first stage, of course, is dilation. Dilation has 3 phases, and we're going to talk about the early, the mid, and the transitional phases. And then we'll move into the second stage, which is actually delivery. So the first stage, of course, begins when they start to feel those regular contractions. And remember, those regular true contractions are what starts to opening of the cervix, or dilation of that cervix. And that's when we start to see that softening and the shortening of the cervix in preparation for that delivery. So this is your first stage of dilation. It begins with the onset of regular contractions, and it ends with complete dilation of the cervix. So we're at a 10 centimeters within the first stage. Now don't get confused when we're talking about the early, the mid, and the transitional phases, because each of those has their own dilation stage. But for all purposes as far as testing, you want to make sure that you know that the first stage begins with the onset of contractions throughout the complete dilation process, and that cervix has dilated to a 10. Now, this is typically the longest stage, especially in first-time moms or the nullipares that we've talked about. This can typically take up to 10 to 12 hours. Now, other parents who have had previous deliveries typically is a lot less than that, usually maybe 6 to 8 hours or something of that nature. So as I said, the first stage is divided up into 3 phases. So let's start with the early latent phase. This is when our cervix dilates from 0 to 3 centimeters. So the contractions are occurring about every 5 to 8 minutes, and they usually only last about 20 to maybe 30, 35 seconds. Now we're talking about the dilation of the cervix. If you compare that to the size of a penny, that's about how large that cervix is dilated at this point in time. Okay, so about the size of a penny is 3 centimeters. Typically at this stage, your moms are still alert, they're very talkative, they're not in a whole lot of pain, so it's fairly easy to control that pain if in fact they are having some pain from those contractions. Maybe just assist them or educate them on some deep breathing and relaxation techniques. Okay, the most common complaint during this stage is back pain. So with that, what we typically recommend is maybe doing some back rubs. Hopefully they have a support system that will do this for them, and that will help alleviate that. And so there's a theory, and it's called the gait control theory, and I'll tell you how that works. So in the gait control theory of pain, it's especially shown that non-painful stimuli, something that's good or pleasurable stimuli, tends to close those nerves off, or close those gates that allow the sensations of pain. So by turning on those positive stimuli, you're better able to control those negative or painful stimuli that a person feels. So here's an example. Let's say you hit your shin on a bed frame, and you might immediately stop to rub that area of injury because it hurts. So that increase, or that normal touch, that soft touch, tends to inhibit those pain fibers and lessen the feeling or the perception of pain. So what we've done in turn is we've turned off those gates of, or the gates that control that pain. So when we've bumped or hit or something and we rub it just a little bit, it tends to hurt just a little bit less. So this gate theory is very important in all stages of delivery. Okay, so now let's go back to the early phases. Many mothers are typically not at the hospital at this point in time. I think I said that previously. As long as they can control that pain at home and they do not have any signs of that membrane being ruptured, okay, they typically stay home. Sometimes they'll even come into a facility and they'll check them and their cervix is not dilated at all, or maybe they're just at a 1. They'll typically return home to kind of wait for that progress into the later phases or until that membrane ruptures. So remember, we talked about how to determine whether or not that membrane has actually ruptured with that nitrazine testing. So when they come in, and maybe they're checking to see if they do need to admit them, if that membrane is in fact ruptured during this early phase, they're going to use that nitrazine testing. And remember your results for those, okay, whether it's blue or yellow, what the pH is, and what each of those mean when we're talking about the nitrazine testing, okay? So that's your first stage of delivery, or first stage, which is dilation, and then we will talk about the second stage, which is actually delivery. Wait, sorry, I've gotten ahead of myself. We're going to talk about the mid phase first before we move on to the delivery stage. We haven't gotten that far. So in the mid or the active phase, our cervix is dilated from 4 to 7. So during this point in time, you're going to start seeing those moms pant just a little bit when they start to see or feel that need to push. Okay, contractions here are typically coming about every 3 to 5 minutes, lasting a little bit longer, about 40 to 60 seconds. Moms at this point in time are a little less talkative, and they're focused on just that breathing, to breathe through those contractions, because they're coming a little faster and they're probably becoming a little more intense. So sometimes at this point is when you start seeing those moms ask for some pain medication. Sometimes it's still manageable without medication, as long as they're breathing through that, using some of those distraction techniques, and then of course going back to that gate theory, turning off those pain receptors with maybe some back rubs or something other that's a little more pleasurable. Now, the last phase in the first stage of dilation is going to be our transitional phase. This is where we're actually fully dilated to 10. Okay, so we've moved from 8 to 10 in this phase. Our contractions are coming a lot quicker. They're every 2 to 3 minutes, and they're typically lasting up to about a minute and a half. So the intensity, of course, is a lot more intense now. These parents or these moms are so easily irritated, so we want to minimize that stress for them. This, of course, is when they truly want to consider some pain medication, unless their birth plan has stated otherwise that they don't want any. They, of course, can change their mind. That is not a contract by any means. It's just a way for them to put their thoughts into a paper form before coming to the doctor or the hospital for delivery. So it's not a contract. It's just a birth plan, and kind of with their thoughts in mind. This is where you may start to see them asking for those epidurals. Okay, they may change their mind and they want that epidural. Now, sometimes when you receive an epidural, it does tend to delay contractions just a little bit. They're slowing the process, so their contractions are not as forceful. Sometimes these patients tend to be very nauseous, and that could be either from that epidural or some of the medications they're taking, or even just the pain of the contractions. So just be mindful about assessing for that and medicating that if possible. So those are your 3 phases, the early, the mid, and the transitional. So the important thing with those to remember are the phases themselves, and at what point the cervix is dilated to for each phase within those. And remember, of course, that gate control theory and what that means, and then use that back rub as an example when you're thinking about that. So then we'll move on to our second stage of delivery, which is delivery. Now, the second stage of delivery. The second stage is the stage that begins with a complete dilation. So our cervix is at 10 centimeters and ends with the birth of the baby. This can last anywhere from 30 minutes, depending on how well those contractions are and how well mom is able to push. And sometimes for first-time moms, it can take 2 hours or so. So it just depends on several factors. So it can vary. Now, our contractions are still coming about every 2 to 3 minutes. And again, they're still lasting about that minute to a minute and a half, or maybe just a little bit less. Now, during this time, we truly want to be monitoring that fetal heart rate. Every 5 minutes, we should be documenting that. Of course, we should already have some types of monitoring in place. Typically, at this point in time, we do have some internal monitoring. That little transducer has already been placed. That transducer is just like a tiny little corkscrew that they will screw into typically right into that scalp area. It's not really harmful, but of course it is a route of infection, so we want to monitor that once we have delivered this infant. So we monitor our fetal heart rate. We do have some outside monitoring as well. Should have those fetal heart monitors inside and out. Our mom is completely dilated to 10, and they're going to start to feel that uncontrollable urge to push. Now remember, that's our secondary powers, that uncontrollable urge to push. So this is when you're going to see your nurses start coaching those moms. We're going to coach them to push, push, push through contractions, and then when they stop, we're going to ask them to rest. Gives them just a few minutes to kind of breathe through that and relax for just a moment. Now they're going to start assessing the situation here. And if they feel like maybe mom's pushing, 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 and maybe that baby's head is just a little bit large and mom's pushing just as hard as she can, but that perineum area is just not giving enough leeway for that baby's head to come through. This is where you're going to start to see either your physician perform an episiotomy by doing a surgical incision, or sometimes if that mom continues to push and it's not giving enough expansion, you're going to see that mom tear. Okay, so there's a couple of types of episiotomies that we want to talk about. One, of course, is a midline, and that's just a straight cut right down the center of that perineal area. Now, because that particular one can actually tear all the way down into the anal area, we truly want to try and avoid that. Sometimes a physician will do an episiotomy that's called a mediolateral, which just involves the cutting of the muscle either to the left or the right of that midline area. So there's less risk for further injury. Now, when we talk about those episiotomies or a patient who is torn during delivery, we want to be mindful post-delivery to educate those moms about the possibility of infections, some bleeding at that site, and even after they're released, within that 6-week time frame, they can still have some pain with intercourse. So just be mindful that that's normal. Let them know that, and to report any signs and symptoms of infection. A lot of them will have an area, if they're torn, or even the cut that's stitched. So either they will go back for those stitches to be taken out, or some of them, as you know, just dissolve. So it just depends. So we want to be mindful in assessing that area also. So that kind of concludes our second stage of delivery. And just remember, the most important part about that is that it begins with complete dilation at 10 centimeters, and it ends with the birth of the baby. So second stage. Now, when we're talking about monitoring that fetal heart rate every 5 minutes, I want to talk to you a little bit about things that can happen during delivery. So at this point in time, we can have some cord compression, and that's not good, because when we compromise that cord, we're compromising that oxygen flow to the infant. Now, there's many times during delivery, in those stages. If we see that cord compromised and that infant's heart rate keeps dropping down into or bradycardia, however you want to describe that, those are the moms that you'll see sometimes if they can't get that baby out quickly, you're going to see them rush off to a C-section because of that cord compromising. It could be that it's wrapped around their neck. I've seen that happen many times. And so as they're squeezing that infant, those contractions, they're squeezing that umbilical cord, and that compromised system is there. So we're depriving them of that oxygen. So that's where the importance of that every 5-minute monitoring comes into play. I've seen infants who've had compromised cords come out and they have that massive CNS depression. You know, they're acute respiratory distress, they have very minimal movements, they have to be intubated because we've suppressed that oxygen to the brain for so long that they end up with some severe deficiencies. Now, another thing we need to talk about during this stage is also the different types of deliveries. We know there's water deliveries and moms who are delivering at home. So there's various different settings. And of course, gravity is always our friend. So now some moms have a preference. They may like the sitting. They may be squatting, kneeling. They may even be on all fours if that's what works best for them. So remember, it's just patient preference. Typically in our facilities, you're just going to see that reclining position for vaginal deliveries. Now, if you're having a C-section, of course, you're going to be laying flat in an OR, and they're actually going to have your arms restrained. Okay, so don't really get an option when you're having. So we've now delivered this infant, and we want to talk about establishing an airway. The first thing that you immediately want to do, of course, is to establish that airway. You want to suck out those airway passages. So mouth first, nose next. So we can make sure that we have a patent airway. This will help us determine whether or not this patient needs some assistance, either from just a nasal cannula, just some blow-by to get them started there and get that O2 saturation up, or if we don't see that that patient has the ability to breathe on their own, if this baby has been compromised, then we may need to intubate this patient. So we want to assess and establish a patent airway immediately. Now, when we talked about the second stage of labor, and that was our delivery stage, this is when you might see some obstetricians begin to use some instruments to assist deliveries. Remember, you have to be mindful of any type of vaginal trauma when you're using, especially a forceps delivery. So they may be using a vacuum-assisted delivery or even forceps. Okay, so mom's pushing, and she's just been in labor for 2 hours and we're not getting anywhere. We want to avoid a C-section if at all possible. So then you'll see them use that vacuum-assisted for delivery. So not only are we possibly introducing some trauma to mom's vaginal area, we can also see some major trauma with an infant's head. I've seen many hematomas and things like that when they've been delivered with a vacuum or a vacuum-assisted delivery. So we want to exhaust all efforts before moving along to those assisted instrument deliveries. Stages, continuing with the stages, we're now in the third stage of delivery, which is where we begin delivering of the placenta. So if you look at the video that I have put here underneath the third stage, it is graphic. It's a real delivery, a real person, and it's going to take you from crowning all the way through to the delivery of the placenta, and you can see that. So if your stomach can handle that, you're not going to pass out on the floor or vomit in some cases. Please watch that. It'll kind of give you a better picture of also those cardinal movements. So if you want to watch that, feel free. If you don't, that's okay too. So the third stage is actually just the delivery of that placenta. So our baby's been born and we're now delivering that placenta. So know that the third stage begins with the delivery of the infant and ends with the delivery of the placenta. Okay. Now, in the third stage, in order to deliver that placenta, that parent or that mom is actually going to receive some oxytocin to continue those contractions so that she can expel that placenta. And if you watch the video, you're going to see them give that to that mom IM, and that's okay. But most of our parents or our moms have a central line or an IV line, and they will usually give it in one of those. Now, the average time, we've talked about this just a little bit before about the delivery of the placenta. Typically, if it's a vaginal delivery, it's about 5 to 20 minutes. Now, if you have a C-section, it takes them all of 5 minutes to separate that and to take that out, deliver it. So once it detaches from that uterine wall, if you see in the video, they're kind of putting a little pressure or a little resistance on that cord after they've clamped it. And that's just so that they can tell when it starts to separate from that uterine wall. So once it detaches from that uterine wall, you're going to start to see that pouring out of blood through that vagina. Okay, so then what we want to start watching for is muscle tone. It's very important that we check that muscle tone and we massage that fundus. Now, massaging your fundus is not what you think it is. And for those of you who've had children and you remember that, it is not a massage. Not in the same way that you would go to a spa and have a massage. It's painful in some cases, but that's how we get that fundus to go back to its normal stage. If we don't massage that fundus and it stays boggy, our patients could in turn bleed to death at that point. So that's why we massage that fundus about every 10 to 15 minutes post-delivery. So after delivering that placenta, typically this is when you'll start to see that physician repair that episiotomy, or if there was a tear, they're going to do their repairs while they're there. Now, a typical blood loss is about 200 to 300 mLs. Now, if you have a patient who has lost more than about 500 milliliters of blood, that's considered excessive during a vaginal delivery. And typically they will have blood on hold for you. So they've already topped your blood and had that at the bedside or in storage waiting, just in case something were to go wrong and you need that. Okay, so one important thing that you need to know about this particular stage is oxytocin, and we give that because oxytocin actually stimulates those uterine contractions, okay, and that's what also prevents that post-delivery hemorrhage. Okay, so as that uterus is contracting, we're hoping that that muscle tone starts to go back to its original state and stop that bleeding. Okay, so remember that oxytocin. Now, oxytocin, or some may recognize it as Pitocin, is the same thing we start for moms when we want to induce labor. Okay, we're going to start causing those contractions. So Pitocin can be given prior to delivery, and it can also be given in that third stage of delivery to help with that muscle tone after delivery, to help with that bleeding. So oxytocin is a very powerful hormone. You've probably heard of this one called the love bug or the love hormone. This hormone is actually what facilitates bonding and empathy, and even when we start to breastfeed, that milk release. So oxytocin is a hormone that is greatly stimulated during the birth of an infant, of course, during that delivery stage. It also happens during sex and breastfeeding. So you may have heard the old story about if you want your baby to come quickly, if you're post-due, have sex, because it actually creates or stimulates that oxytocin that will bring on those contractions and start labor. So that's where that old story comes from. So that's your third stage of labor, and then we'll move on to the fourth stage, which is actually stabilizing our mother. So the fourth stage of labor, of course, is our stabilization. This is the time where we have to absolutely positively monitor for that bleeding and make sure that we're massaging that fundus to get that tone back to where it needs to be. And no, it is not comfortable for that mom at all whatsoever, even if it's a vaginal delivery or a C-section. It hurts. It is not pleasant, but it is an evil necessity. So our fourth stage in the stabilization is the time immediately after delivery, in which that mom is trying to recover from all of her labor efforts. So it's extremely critical during that time to monitor our mothers. Um, Typically, this particular stage is typically 2 to 4 hours is when we want to really focus on that mom and her recovery. So for the first hour, we're going to assess that mom for about every 15 minutes. And then if she's okay after that length of time, we're going to move into 30-minute monitorings for that. So we just want to be mindful of assessing her, taking care of any of those needs as far as pain after delivery, whether vaginal or the other. And if she's had an epidural, we want to make sure she's starting to regain some of that feeling in her legs before we ever get her up to move her about. This is also an important time for bonding. We want to make sure we're offering time with that mom to bond with her new infant. Hopefully get that baby doing some skin to skin, and even maybe mom probably has a little bit of colostrum in there at this point in time. You could put that baby to breast just to promote that bonding of mom and baby, as long as she's feeling able to do so. And then, of course, this is another time where we want to include family, especially if there's a husband, father, or partner involved. We want to involve them as much as possible during that bonding time also. So that's our fourth stage. Remember, that stage is we've already hopefully stabilized our baby, and so this stage is extremely important for mom. So the biggest thing that you need to be aware of is monitoring for bleeding at this point in time and doing whatever necessary to prevent that hemorrhaging. So you've heard me talk a lot about monitoring the fetal status, certainly during the delivery process. Again, when we're monitoring that, we have to monitor every 5 minutes because we want to make sure that we're not missing any signs of distress in that infant. So we have two types of fetal monitoring. We have an external and we have an internal monitor. You can see in the slide there's an external, which is placed on the abdomen of the mom. And then you also have the internal. This is the one I talked about previously, that was like a little corkscrew that they basically go in through the vagina and put into the surface area of the scalp or presenting part, whatever that might be. Hopefully it's the head. So when we are talking about the external monitoring system, it uses a tocotransducer. So it's monitoring that uterine activity, and this one records frequency and the duration of the contractions. Now, the difference in the two is extremely important, especially when it comes to testing. So your external Your tocotransducer will only record frequency and duration of contractions. It cannot measure the intensity of the contractions. Okay, now this system will actually print out what we call a fetal strip, and it prints out the fetal heart rate also. So there's two portions to that. Now, depending on how your mom is positioned, it can affect the outcome or the recordings on that strip when you're using the external monitoring system. So the internal monitoring system uses, again, that little spiral electrode. It's kind of like a little tiny corkscrew. And again, it's just put in there and attached to that presenting part. It monitors that fetal heart rate. Now, this one actually allows you to monitor the intensity of the contractions. Okay. So, know the difference between those two. This one can measure intensity, whereas the external cannot. So the internal monitor is a tiny little catheter, and during the contraction, it's compressed. And so then it places that strain on the gauge or the pressure, which gives you that reading of that intensity. Now, the positive thing about an internal monitoring system is that it does not matter what position your mom is in. She can be sidelined, she can be on all fours, she can be standing up, whatever she so chooses. This reading is accurate, okay, no matter that maternal position. Now, this one is only used during the interpartal period because, again, the membranes have to be ruptured. We don't want to go in and place that if that membrane has not been ruptured. And then, of course, your cervix has to be dilated to about 2 to 3 centimeters. Remember, that's about that size of the penny in order to even get that catheter in there to where it needs to be. So those are our two monitoring devices. Make sure you know the difference between the two and what they measure. So let's talk about fetal distress. Fetal distress is never a good situation. Typically, it results from hypoxia. Remember, we talked about that cord compression. And then, of course, with our decels, when we talked about those late decelerations, that's when our heart rate slows down, and then there's never really a return to baseline. Okay, so you have that non-reassuring heart rate pattern. Never good. So this really just clues us into a progressive increase in that stress level. So the variability, tachycardia, the severe bradycardia, and then those persistent late decelerations signify something is going on and it's stressing our infant. Remember when I talked previously about stressing an infant, what can happen sometimes is they will go ahead and release that first stool, which is that meconium staining, or that meconium, the green, dark, tarry stools. So it stains that amniotic fluid. And remember, we talked about how the ingestion of that can cause severe respiratory distress in an infant because our lungs are not able to function properly because of that thick, tarry stool that they've ingested. Their lungs can't expand, and that alveoli cannot work appropriately. So we end up in fetal respiratory distress, and most of these infants end up intubated right at delivery. Now, as we talk about our fetal monitoring systems and fetal distress, it is extremely important for you as a nurse to know that you have to be able to interpret those fetal heart rate monitoring strips. So from those external monitoring strips and the internal, you have to be able to indicate whether or not we're moving along in the normal or in the right pathway, because you are legally responsible for interpreting that and reporting that to the physician. Okay, you need to know what your immediate intervention should be if in fact you do see those late decels on that strip. Okay, so remember, you as a nurse are responsible, legally responsible, for correctly interpreting that fetal heart rate pattern and reporting that. You should notify that physician immediately when you detect any type of abnormality in that fetal heart, in that heart rate or that fetal strip. Now, we're going to talk about some Apgar scoring. Our infant has delivered, and so this is a good assessment of or indication of how well our infant is doing currently after delivery. So an Apgar score is taken at 1 minute and 5 minutes of age. These scores typically range from 0 to 10. If you get a 10, someone probably has not scored you correctly. I have never in 9-10 years of scoring an infant ever got a 10, and I'll explain why shortly. So the criteria for an Apgar scoring is, first of all, your heart rate, of course, your respiratory rate, your muscle tone, and the reflex irritability and the color. Okay, so those are some of the things that we score them on. And I'll include a slide that shows you the point system. Okay, so it's either absent, 1 point, or 2 points for each category. Okay, so there's the 5 categories. That's where you get your 10 points. So a low score, depending on how well that delivery went. If you've had a baby who was stressed and maybe they had that meconium swallowed at, delivery or in the midst of delivery, you may have a baby who comes out at a 1, and that just simply means they have a heart rate, if you're lucky. So a poor score or a very low score indicates some very serious problems, and you're going to probably do some intubation and some major respiratory resuscitation. So a high score again indicates that that infant did well, he tolerated delivery pretty well, he or she, and they're just requiring some routine care. And routine care in a delivery typically means sometimes you'll give them some blow-by oxygen, and what that means is just you're not really attaching a nasal cannula, you just kind of have a little mask close by, just close enough so they can breathe in some of that pure oxygen, but we're not actually putting it on them. Okay, so we're going to look at the heart rate. We want to make sure that they have one first of all. And then according to the point system, if it's greater or less than 100, you get X number of points. Their respiratory rate or the respiratory effort is also rated the same. Is it irregular? Are they putting forth great effort? They're crying, and you can see that they do not need that assistance for respiratory. Their muscle tone, did it come out limp or just flaccid, just kind of laying there? There might be a tiny bit of flexion or just very minimal movements. Or they could be very active, moving, crying, throwing those arms about. Now, when we talk about reflex irritability, that is, okay, I flipped your foot and I've made you cry, or you've maybe made a little bit of an effort to show me that you didn't particularly like me doing that, so you grimace. Okay, so that's going to be your 1 point. Or maybe he made no response at all whatsoever, and you're going to get a 0. So again, just kind of looking at that Apgar scoring system, and again, I will attach that in the next slide. And then the color. This is where I cannot ever see anyone getting a 10. I have never seen a baby come out after delivery, even at 5 minutes, that was totally pink. So in color, you get scored on, are they pale? Are they, their body's nice and pink, and they have some of that acrocyanosis, which is in, of course, the hands and feet. That is typically what you see in an infant for a good, I'm going to say 10, 15, 20 minutes. That's why I can never imagine any infant getting a 10 on their Apgar scoring, because in order to do that, they would have to be completely pink, and I've just never seen that happen. So when we're talking about this Apgar scoring, we, of course, are stabilizing this infant. Usually, if there's a vaginal delivery, all of that excess fluid that they might have in their lungs is squeezed out through those contractions when they come through that pelvis during delivery. You may still have a little bit that you need to remove. And again, remember when you're using that bulb suction, that you start with the mouth first and then move to the nose. Okay. If you look on page 820, I think it's like box 26-4, you can look at that to see. So you want to kind of position the newborn on that right side to facilitate some of that drainage when you're doing that. You always consider about warming that infant. Remember that sac that they were in is what actually helps them maintain and regulate their temperature. So that's their thermoregulation mechanism there. And so we've done away with that. They're out in the real world, and so you can imagine they're wet, they're cold, and so they can rapidly drop their temperature because they don't usually have the fat stores like some of us do. So they tend to drop their temperature quickly. So in order to prevent that, we want to immediately begin drying that infant just to reduce that loss of heat. A lot of times you'll see them the minute they throw that infant up on the baby or the baby up on the mom, they're wanting that skin to skin contact. That is one of the biggest things in helping a mother and baby bond, of course, and then to help that infant prevent some of that temperature loss, that skin to skin contact. Okay, as long as there aren't any complications during delivery, you can do that. Just toss that baby up there after you've given it an Apgar score and let them do some bonding, and mom can help regulate that temperature. Of course, in delivery, you're always going to place armbands on mom and baby. This is done at delivery before anyone ever leaves that OR room or the delivery room. So you'll put an armband on mom, you'll put an armband on baby, and these have matching numbers. It'll have mom's information as far as first name, last name, boy, girl, time of delivery, and things of that nature. And if dad is in there, you can also put a band on dad. Typically, even if they're not married and mom says, oh, yes, I want my boyfriend banded or whatever, you can also band him if he's in the delivery room. So I will be sending out a little practice sheet with Apgar scoring because you will have to score some of the questions on your next test. So if you have any questions about how to score, please email me, let me know. It's not too hard or too difficult once you kind of memorize the scoring system. Apgar scoring is fairly easy. So just be mindful, if you have any questions, just email me and let me know. This is your Apgar visual aid for testing. Anytime an infant is born, they immediately do an Apgar score. So you'll have a score at 1 minute and 5 minutes. And then if it's a depressed score, then you may have another one at 10 minutes. So they're looking for the appearance of that infant. Do they have some type of color other than blue? Okay, are they acrocyanotic? That's where you're going to see the arms and legs that are blue or purplish. That's your acrocyanosis. Now, if they're blue all over, we have a serious problem. I've never seen an infant delivered that had no blue coloration at all whatsoever. 99.9% of them are going to be acrocyanotic. They look at the pulse rate. Do they have a pulse? Number one. Is it greater than 100 or less than 100 beats per minute? And then based upon those assessments, you're going to score them at 0, 1, or 2. Okay, so the highest you can get on an Apgar scoring is 10. I have never given an infant a 10 in all my years of working with newly delivered infants. So grimace, you're looking for that response to stimulation. When you see a nurse flick their feet or rub their chest, something like that. What is their response to that? Do they have a response? Okay. Are they coughing, sneezing, pulling away when they're stimulated, things like that? Activity is, are they flaccid? Do they have any movement? Do they have a little bit of movement, or are they extremely active? Okay, so that is all based upon a score of 0, 1, and 2. Now, respirations are also important. So are they breathing at all? Is it weak and slow? Is it an irregular pattern? Or do they have a really strong cry and they're breathing very well on their own? A lot of infants typically, if there's no problems, will come out with a pretty strong cry. They're upset that they're out in the cold and all of their nutrition's been cut, and et cetera, et cetera. So they're going to have that real strong cry. So they're going to get a 2 for that. And they're usually pretty active. They're going to get a 2 for that. Typically, if they have a strong cry and they're active, their heartbeat is above 100. Okay, now again, I've never given a score of 2 on appearance because every single infant I have ever seen has some type of acrocyanosis, which is that blue or purplish hue in the extremities, upper and lower. So just be familiar with those Apgar scoring. Later on, we will do some Apgar scoring on test, so you just familiarize yourself with that early on. So much of this is just common sense. It's important for all of us to kind of assess how well prepared that mom is for childbirth. Does she have a birth plan that she wants us to be aware of and to have on hand? If so, they need to bring that to us. If she's planning to deliver in the hospital, or is she going to choose an outside facility? Um, Typically, if you have a hospital delivery, all of that admission is done or prearranged and the paperwork's completed ahead of time. If you know you're coming in for a C-section, they'll do this 2 to 3 days or so before your planned C-section. This is when you'll come in and you'll talk to also the anesthesiologist usually. They'll do their paperwork and talk about, what your plan is, what your thoughts are, and just various different questions. If you were to have to go to a C-section, medications that you prefer to use or not use, and things like that. So, of course, most of the time they'll tell you to pack a suitcase with whatever's necessary, but I can tell you when that time comes, you're just going to pick up and go. And then you're going to send someone home later to go pick up your suitcase. Now, with pregnant moms in relation to nutritional and their metabolic patterns, of course, everything kind of slows down during labor and delivery. So we want to be mindful of the things, or at least try to relate to our patients that it's important to remember what you've eaten just prior to the onset of labor. Because remember, if you're a patient and you're going to go have surgery, they make you NPO, meaning you can't have anything by mouth. And the reason for that is a lot of times you can become nauseous if you're receiving anesthesia. And certainly we don't want you in there vomiting during this time because we want to be mindful of aspiration, okay? We don't want to do that. So sometimes you can't prevent that. You may have eaten a big old pizza or whatever right before your water burst, and you're heading to the hospital and you end up having a C-section. There's not a whole lot they can do about that, but at least be mindful of what you had so that you can let them know. There's sometimes they can give IV medications to prevent that nausea, which will then prevent vomiting. So that's the big concern with eating, especially right before they're contemplating any type of surgery, is just that aspiration. So typically when you're in the hospital, once your labor started and they're expecting a vaginal delivery, they may give you some soft items, but they're not going to give you solid foods. It's typically liquids mostly. And then they're going to start your IV fluids just to prevent that dehydration. So again, withholding those solid foods in preparation for delivery. Elimination, as we all know, that urgency returns once that baby drops into place. So it just kind of depends on how much they've had as far as intake, whether it's normal or decreased. But we want to kind of keep them on that bladder training, as we call it, having them void every 2 hours. Sometimes when mothers come into labor and delivery, they used to always put a catheter in prior to delivery. And that's just because sometimes that full bladder does interfere with the progression of labor. It will just kind of slow down those contractions, or it can't get enough force with that full bladder being in the way. So it can interfere with that progression. So we always want to kind of keep that elimination pattern going. Okay. Now, some women can experience diarrhea with the onset of labor. I think that probably goes back to nerves, but just be mindful that that can happen. So we just want to give them as much assistance and support and letting them know that that can be a very common occurrence. Okay, they're going through a lot of changes. So we as nurses really just have to support them and reassure them that they're not the only person in the world that this happens to. Okay, so just supporting them and educating them helps greatly relieve that anxiety. Now, when we talk about activity and exercise, you have to be mindful of activities prior to delivery and those after delivery. Of course, ambulation is always encouraged. That kind of gets everything moving. And then walking actually provides some distraction for that mom. And remember, we talked about earlier on about how walking and activity actually is a sign of true labor, so it can strengthen the effectiveness of that labor. So we want to continue that. Rest is always encouraged with any discomfort or pain, especially if you've been given some type of analgesic, some type of medication to help you relax. Remember, we don't want them falling. Of course, safety is always in the forefront of our minds. So again, in the beginning, low back pain is very common, and we talked about some of those interventions. Remember that gate theory, that gate control theory. Have that person in the room who's their support system. Give them some back rubs, just rubbing that area to help soothe that just a little bit, turning off those pain receptors to the negative, bringing on those positives to bring about some relief. Of course, changing positions. Maybe they're tired of laying on their left side, or maybe they're just tired of being in the bed while they're going through that first stage of labor, which is the longest, remember. So just have them move from, maybe walking to the chair, to the bed, left, right, whatever works for them. Sometimes they've even mentioned warm showers in the beginning for that low back pain. But I, as a nurse, would tell you I wouldn't want my mom in a shower in the middle of labor. That's my personal opinion. But just know that sometimes that is an option. Okay, so just always keep safety in the back of your mind when you're talking about activity and exercise, especially postpartum when we get into that. The last thing you want as a mom to get up and walk when she's had an epidural and can't fully feel her legs. So don't want her to end up in the floor. Okay, so just always keep safety in the back of your mind. So we're going to talk about some psychosocial assessments here, and let's first start with the doulas. Of course, many of you may know exactly what I'm talking about, but this is just a professionally trained person who's trained in childbirth and deliveries. They typically provide emotional support, some physical support. They may be the one there holding their legs as this mom gives birth. Um, their main purpose is to just help with any type of stress, maybe to calm them down, help them just think about certain things, and they may be there just to empower that mom during this whole birthing experience, knowing that this person has someone, a companion, if they're there alone, no husband, no boyfriend, significant other, just to kind of help get them through that experience. Now, when we talk about some stress tolerance and some coping mechanisms for this mom. This is where your doulas really come into play. They're knowledgeable in the power of massage and touch just to reduce some of that anxiety during the labor and delivery process. So that massage, again, is going to help release some of those natural oxytocins, okay? So then that just helps that mom through the process and then to begin bonding with that new infant. So they play an important part, and we want to make sure we include them, just as well as we would want to include if there is a partner, a husband, boyfriend, whatever, in the room. We also want to include them in any portion of that process that we can. We don't want to just set them in a corner and let them observe. Okay, they're there to support that mom also. So we want to make them feel welcome. Again, we're talking about some psychosocial assessments here. Going back to those values and beliefs, of course, we don't all believe the same thing, and this goes back to our cultural awareness and assessments. Um, there are various different ones, and so the earlier we begin to talk to our patient about their beliefs or their preferences, the better able we are to provide those. So in some of like the Southeastern Asia, those Iran areas, those fathers are not present for birth. For whatever reason, they're not typically present. And that's their belief. It's been like that forever. Now with American Indians, they may want their whole entire family in there. And I know that sometimes space is limited, but we always want to try and accommodate that to the best of our ability. Some others are, let's see, I was trying to think of a few that I've remembered previously. Can't really think of any that come specifically to mind right away, other than there are some cultures who don't allow their mothers to actually leave their bed for upwards of 30 days or not leave their home for 30 days. And their mother-in-law is actually the one who takes care of their infant rather than mom. So if you're in a facility and you see a grandparent taking more interest or caring for that infant more so than the mom, we of course need to address that or assess that situation, but it could just be a cultural value or a cultural practice. So one of the big things we also have to be mindful of You guys may remember a case in which the American Disabilities Act, those people were called in a couple years ago because a family lost a child actually in one of our local facilities, um, because they were unable to communicate. Even though they weren't the patient, they didn't call in an interpreter. Their daughter knew what was going on, and their daughter was the patient, and she was able to communicate with the physicians, but the parents were not. So there was a huge lawsuit about that. So anytime you have a non-English speaking person in labor, you want to make sure and use that language line. And it may vary from place to place, but in facility where I worked, we had this little thing, we toted it around much like a medication cart, and it was called language line. So you would dial in, tell them what language you need interpreted, and then they would find an interpreter for you. So be very cautious about using other family members for interpreting when it comes to your patients. Always make sure that you have a certified interpreter available. Now, when we talk about precipitous labor or emergency births, this is just someone who is maybe in preterm labor. They walk in the door, boom, they've had their baby. Or maybe they are on their way to the hospital and they've had this infant in the car on the interstate. Okay, so they're extremely stressed. They are not really sure what's going on. And they've had this precipitous delivery. So we really need to support this family, and just assess their needs at that point in time. So the nursing process for normal labor, we've talked about the nursing process previously. I know you guys are sort of familiar with it. It's that mnemonic called ADPI. So your assessment of your patient, and then of course your diagnosis. Again, this is your nursing diagnosis, not your physician diagnosis. So some of the nursing diagnoses that we might use or see during labor would be acute pain, fatigue, of course, during that whole labor process. We know how long and intensive that can be. Risk for infection, anxiety, and fear. So we can diagnose these moms with just about every single one of these in relation to labor and delivery. And of course, you can always include knowledge deficiency, or a risk for a deficient knowledge. So those are going to be our diagnoses. And then planning is our next one in the nursing process. So we want to plan ahead of time. So we want to sort of plan on certain things we can do as far as reducing that risk of infection, make a plan for reducing that anxiety. How are we going to get them to cooperate? Okay, and then we're going to implement. So the way we're going to implement some of those plans that we made are going to be to provide some emotional support. We're going to educate them on some ways to lower their risk for infection. We want to help them with a supportive environment, and we want to educate, maybe their family members or their support system who are there on different ways to, provide that emotional support. We're going to be sure that we're educating and explaining any of the procedures, and again, asking, do you have any further questions? Is there something else I can elaborate on to help you better understand, just to relieve that anxiety and that fear going forward? And then, of course, we always provide that physical care after delivering a baby. We're not always in the best mind frame, nor are we, especially after a C-section, really able to take care of ourselves in a manner that we would normally be able to do so. So we're going to have those nurses and those CNAs actually providing some of that physical care. And lastly, we want to, again, provide that encouragement, encourage that mom and praise her for, you're doing a great job, especially first-time moms, feeding that infant or picking up on cues, or you did a great job, changing that diaper for the first time, or swaddling that infant. So just make sure that you're providing that encouragement to those families, even the parent, not mom, whether that be a significant other, dad, whoever that support person is. If they're a first-time parent or they're playing that part of that father or whatever, be sure that you're encouraging them too and including them. And then, of course, our evaluation is always going to be, did everything that we plan and implement, is it working? Did we see a positive outcome? And if not, then we go right back to our assessment and start over. So always looking for those, the whole parts of that nursing process. Okay, that's important, and it's a never-ending process. Induction of labor. This is typically not how we want to start labor. However, many times, especially those who are post-due or post-date, will typically end up being induced. And this is typically not a comfortable situation because when we start giving certain medications, their contractions are intensified because of the medications that we give, that Pitocin, in order to start that induction. So there are a couple of ways to do that. First of all, a couple of things first is some contraindications for an induction would be if they had a cord prolapse or active herpes. Anytime you have someone with active herpes, they're actually going to be a C-section case. They will never, ever induce someone who has active herpes. Or if you have a patient who has placenta previa, that just means that their placenta is in a low area of the uterus, and it may interfere with actual delivery of that infant in the passageway. So they're going to actually be a candidate for a C-section also. So sometimes when they want to start the induction of labor, they will do an amniotomy, which is basically going into the vaginal area, and it almost looks like the tool they use looks like a little knitting needle or a crochet needle, I should say. And they'll go in and they take that little hook and they'll break that amniotic sac. And then they'll start that oxytocin or Pitocin administration. And so that's how we induce labor. Now remember, once we've broken that actual, the membranes or that amniotic sac, we want to immediately start assessing that fetal heart rate. Okay, that's important. Typically they'll allow about 24 hours once they've started that induction. If not, that puts them at a prolonged risk for infection. So they will consider doing a C-section. Now, once we do an induction, they have prostaglandin gel. And so what that prostaglandin does is it will ripen that cervix so that it can start that process of effacement. Okay. Typically, that gel is instilled directly into the vagina, and it usually starts to work within an hour once it's been introduced. Now, while we're given oxytocin, a couple things to be mindful of in monitoring your patient especially is going to be that fetal heart rate and the consistency of their contractions. So we want to make sure that if we see an elevation in that uterine pressure, usually about 15 to 20 millimeters of mercury when we're monitoring, we want to maybe stop that. Of course, notify your physician. But if they're coming faster than every 2 to 3 minutes, if they're having a contraction every single minute, they're not getting any time in between to rest. So we want to notify that physician, and especially if we see any changes in that fetal heart rate. Okay, because if we're contracting and contracting and contracting, and we have some sort of compromise within that cord, we don't want to keep contracting every minute. Okay, we want to slow that down. So it may just be a matter of slowing down their infusion of oxytocin, but that's for the physician to decide. I've talked a little bit previously in another slide about assisted deliveries using certain devices. So we have forceps, we have a vacuum, and then of course cesarean delivery. Of course, cesarean is when we're going into the OR and we're going to surgically remove this infant. So with the forceps, they're kind of like a spoon-like device, and it just basically fits around that fetal head to help once we've started the process and it's engaged in that pelvic area, we can just kind of help that along. Okay, we always want to closely monitor again that fetal heart rate, and we want to be mindful of causing any trauma to that vaginal area. Now, when you use forceps for delivery, you have to also be mindful of any trauma or anything to that fetal head. Of course, a lot of times when we use those types of assistive devices, we do have some bruising, and then of course some edema can temporarily occur. Again, monitoring those lacerations with that mom and any increased bleeding that may have happened during the use of those forceps. Now with a vacuum, it's basically like a suction cup, and it's attached to that fetal head. It's almost like a negative pressure sort of, and it's just when that mother pushes, it sort of helps extract that infant, if that makes sense. Now, with that vacuum extraction, a lot of times you'll see them with some fluid, that edema in the scalp and bruising. And I'll attach some pictures so you can see what we call it is a capitocecedum. And there are a couple of different things about those. Some cross the suture lines and some do not. And we'll talk a little bit further about that once we get into the actual newborn portion of this class. But anyway, I will attach to let you see the difference in the two, the vacuum and the forceps delivery, and what that head could possibly look like. So if you want to look at both of those videos, you can watch the delivery of both of them using the two different devices. VBAC may be a term that some of you have heard and are familiar with, and some maybe not. That just simply means a vaginal birth after a cesarean. So sometimes women who have an infant who is delivered by cesarean section only because he's breech, or maybe has a very large head and the pelvic area is just not measuring quite right, they can often let them try to have a vaginal birth after having one infant by C-section or a couple of infants by C-section because maybe they were breech. So that is a possibility, and of course your physician will assess for whether or not they will allow you to do that. So that is possible to have a vaginal birth after a C-section. Now most C-sections of course are typically done because either they've had a previous C-section because of that small pelvic inlet, or the baby was breech, or sometimes they may have a cardiac condition. That mom may have a cardiac condition, and they've just suggested not putting her through that process of labor with all that pressing or pushing and putting that additional stress on her cardiac output. Any type of abnormal condition of that placenta. Remember I talked about the placenta previa where it could be actually low lying and preventing a full passageway of that fetus. Some type of infections. I mentioned herpes. Anytime you have active herpes, they're going to do a C-section. any type of, some type of pelvic abnormalities, just a difference in the bone, something maybe that's just going to impede that delivery process. And then, of course, always those fetus compromising situations where they have prolapsed cord, transverse, of course, when they're, I call it sideline, or any type of hypoxia that you see, that cord compression, or maybe that cord's around their neck or something of that nature. Okay, so those are some of the reasons that they would do a C-section. So it doesn't always mean that you cannot have a vaginal birth after C-section. It's possible, so that's what that's meaning, that VBAC. Okay, and then the business of being born is just a funny video. If you guys want to watch it, it's kind of funny. So that concludes this portion of chapter 27. So if you guys have any questions at all whatsoever, please email me. If there's something you don't understand, maybe I can explain it a little bit better to you. So again, I'm here for you. Just let me know if you don't understand something. I'll be glad to help you and maybe to elaborate a little further on that subject.